All right. Let's talk you through this picture a little bit because I really like this picture because it has everything in one picture as far as at the spinal cord level, that cross section through the spinal cord, and then dorsal and ventral roots into the peripheral nerve or the spinal nerve, into the dorsal and ventral rami, and so forth. It just gives you a good overview of all the things that are happening in that cross section and those connections there. Um, this will be good also as a resource when we get to the spinal cord and we start going through all what's happening at the spinal cord level. But I think you're ready to see this now for both motor, the autonomic we just talked about. So this is a cross section through a spinal cord, and we know we're in a thoracic level cross section here because we have a little lateral horn right there. Okay, and also in a cross section through a thoracic spine, the ventral and dorsal horns are actually kind of small. You'll notice that the ventral and dorsal horns are kind of small because you have, from the sensory standpoint, you have kind of these large receptive fields, and the density of the neurons are less, so you don't need as much gray matter for the dorsal horn. But also there's less motor. There's less, you only have some intercostal muscles and some obliques and things you're supplying, so the dorsal and ventral horns are pretty small. But then you also see that little lateral horn for the autonomic nervous system. So let's just point out a few things here. So here's our dorsal root and our ventral root. Here's our dorsal root ganglion. This is the spinal nerve right here, right before it divides into the dorsal ramus of the spinal nerve that goes back to the back part of your body, and then this is all the ventral ramus going this way to go to the front part of your body. They're just not showing all the same stuff that's going out the ventral ramus, all this stuff also goes out the dorsal ramus. They're just not showing that. Okay, so you still have autonomic, motor, and sensory going out the dorsal ramus of the spinal nerve. Where is that? There we go. Let me erase some of this stuff. Now, I'm realizing I think I made a mistake when I was talking the autonomic nervous system, and let's show you the pathway here, and here's the preganglionic sympathetic cell body in the lateral horn, okay, where it starts. So the sympathetic efferent goes out the ventral root, goes into the spinal nerve, goes into the white ramus, and I think I was telling you that was the gray ramus. I can't remember. I'd have to go back to it's on tape, so you can prove me that I was wrong. So just make sure you're comfortable that this is the white ramus here, the first one. So it actually bypasses the gray ramus to enter the white ramus, makes its connection, and here's the cell body here, and then this is the gray ramus. And I think of maybe, and I should have remembered this, is the gray ramus. It's closer to that cell body. Cell bodies are gray matter, so that's why the white ramus that it goes in first, this farther away, it's the white matter axon going in. Even though it's an axon coming out, it's closer to the gray matter here in this sympathetic trunk ganglion. Okay, that's the sympathetic ganglion that are connected by a trunk. Some of those may go up or down a few levels before they make that initial connection. Goes out the gray ramus and then goes to, wherever it's going, blood vessels, smooth muscles, glands, those kind of things, autonomic function. Okay? So those are some things just to be aware of. You'll also notice we're going to be getting into this. So this is a nice picture. It has here the dorsal columns back here with the fasciculus gracilis, and then there's no, and it does fasciculus cuneatus. So actually, you know what? So we could tell that this is a thoracic level segment that has to be above. It's got to be between T1 and T6, because T6 is when you actually start adding on the fasciculus cuneatus. So just by looking at that lateral cell, that lateral horn, and the fact that it's got a fasciculus cuneatus, we got to be above T6. So we're in T1 to T6 thoracic segment with that. We can't narrow it any further than that unless we have some additional information about maybe which muscle it's actually innervating or something like that. But it has all these major, it has the substantia gelatinosa here. It's got the spinocerebellar tracts. It's got motor tracts here. It's got everything in here. The spinal thalamic tract, here's more spinal cerebellar tracts, the thoracic nucleus or Clark's nucleus. So it's got a lot of cool information all in one picture. So we're going to talk about the motor system. Anybody actually want to admit they've been to a tractor pull? These aren't the kind of motors we're going to be talking about today, but who's yeah, all right, man. I used to go to some of those. Actually, San Diego used to have some at at the stadium where the Chargers played. They had tractor pulls there. I remember my dad took me to a few tractor pulls. I just remember like when the engines would blow up, the whole thing, the supercharger just blow off. You always be waiting for it to blow up because the whole thing would like, it's got this little frame and they've got like 7 or 8 motors or 12 motors attached to it. And if one blows up, the whole thing, like even the frame will crack and like it's crazy. So anyway, it's not that exciting unless something blows up though. So you're just waiting the whole time. Come on, blow, blow. But this is the motor system we're talking about. So it's got some major components to it. It's got the cerebral cortex. That cerebral cortex plays its primary role as in voluntary motor activity, right? When you're actually choosing to do a voluntary choice to do some, especially fine distal control and voluntary movement. And there's 3 areas that we'll talk about that are important to motor control that are in the cortex. Okay, the primary motor cortex, the premotor, and the supplementary motor cortex. And they all have a little different slight role. Next week, we're going to be talking about the control circuits. These are called the basal ganglia and the cerebellum. Have influence over your motor output. So you're sending a signal down from your brainstem or from your cortex to generate a motor output. They will have those signals will be always influenced by the basal ganglia and the cerebellum. They will be modified or influenced on their way down. They'll have to stop by before you send a signal to do a voluntary motor act. You have to go through the basal ganglia first, and then it goes back up and then releases the signal to happen. And then as that signal is going down, your cerebellum can be modifying activity in interneurons at the actual spinal cord level where it's going to interact with that anterior horn cell and modify that muscle motor output. So these are the control circuits that influence the individual signals you send to tell muscles what to do will be influenced by both the basal ganglia and the cerebellum. Then we have the descending pathways, the pathways that carry this information through the spinal cord is what we're talking about here. Well, I should say through the brainstem and spinal cord. Cerebrum, brainstem, and spinal cord. Through the central nervous system. Let's put it that way, CNS. We can loosely divide these or grossly divide these into a medial activating system of pathways and a lateral activating system of pathways. How many of you guys have the 3rd edition of Lundy-Ekman? Does anybody have the 3rd edition of Lundy-Ekman, or are you guys all pretty much 4th and 5th editions of the Lundy-Ekman book? Okay, so they made a pretty significant change, and I actually didn't check the 4th edition. So the 3rd edition includes some pathways that they no longer talk about or include in at least the 5th edition. I don't know about the 4th, but we will talk about them because your Crossman book, the other book, does talk about these pathways, and many other textbooks and research articles you'll read will mention these pathways. So I want you just to be a good consumer of that literature. So you will still be responsible for what I present that's slightly different or in addition to your Lundy-Ekman book. But I'll be considerate of that when I'm writing questions and those kind of things, and I'm not going to pick on you guys to try to trick you or anything like that. So let me just point out those differences that you may not see in your 4th or 5th edition of Lundy-Ekman. This tectospinal tract, your 5th edition for sure does not mention it. Does your 4th edition mention the tectospinal tract? Did anybody see the tectospinal tract in the 4th edition? Don't remember, or probably not then. But there is a tectospinal tract, and actually, and then the 4th and 5th editions also do not talk about, they do not divide up the reticulospinal tracts into a pontine medial or a medullary lateral reticulospinal tract. All they talk about is just reticulospinal tract. They just talk about it as together, as if they're just one reticulospinal tract. And there's like a very small blurb about it. There's actually, those can be subdivided into two discrete pathways that have some slightly different functions. And they actually talk about, in your 5th edition, they mention one of the reticulospinal tracts as doing the same function as the tectospinal tract. So what I'm thinking is they actually did is they grouped the tecto with, so they're referring to a reticulospinal tract that subserves all the functions of these 3 pathways that we used to, or in the 3rd edition, would subdivide, okay? So just giving you kind of a heads up. I get frustrated when they change that every year, but Crossman talks about, the Crossman book has all of those pathways. So I'm actually going kind of by Crossman's book, and actually, like, for looking at the pathways and visualizing them, Crossman does a much better job of just seeing those pathways and understanding them than the Lundy-Ekman does. And actually, when I put the slides up of the pathways, they'll actually be pictures either from Crossman or from another resource that does a better job of showing these pathways. Then, of course, we have our lower motor neurons that they're coming from that anterior horn cell, or anterior horn area, and they will be either an alpha motor neuron that goes to the extrafusal skeletal muscles, or a gamma motor neuron that goes to this muscle spindle and the ends of the muscle spindle to adjust the tension or length of the muscle spindle within the muscle. So that's an overview there. So talking about movement, movement is orchestrated by coordinated action of the peripheral, spinal, brainstem, cerebellar, and cerebral regions, including the basal ganglia in there, the cerebral regions, and it's shaped by a specific context. Movement is always within a specific context or environment, so you can't separate movement from your environment. And so, or the intentions of the performer. So when we talk about motor learning, and when we get to our clinical neuro next fall, we'll talk about how task specificity and environment is just as important to shaping movement as your actual nervous system is. So there's an interplay between that. And you as a therapist, you need to understand, hey, this person has a certain motor deficit. I can alter the environment so they can either still be successful, or I can create a certain amount of challenge for their motor system by altering the environment or the task that they do, so I'm getting the optimum level of challenge or learning going on in the motor system. Why do we move? Typically, we move to achieve some type of task or goal. We're exploring our environment. We're trying to influence our environment to our benefit, or to interact or explore it. And that's really important we typically don't move just to move. We don't randomly just move. That's wasting energy. Our systems are designed to conserve energy and only use it when we need it. So this is true in patient care when you're prescribing exercises and therapy to patients. The more meaningful and the more they see a direct relationship between the movement and how it's going to help them in real life, the more likely to be motivated to do it, and the better learning that will take place. So when we talk about neuro, we're always talking about task-specific training. If at all possible, make sure you simulate the actual movement they're wanting to do. You're going to get a lot better benefit of helping them improve their sit-to-stand process by making them do sit-to-stands than doing leg lifts. You know, you're strengthening maybe their quad or the hip flexors when they're doing leg lifts, but is that going to lead to better sit-to-stands? Probably not, unless you practice sit-to-stands. So more than half the nervous system is directly involved with motor performance, moving, okay? And it's interesting is that our primary motor strip is part of our frontal lobe, and also our executive functioning systems are right next to our primary motor strip. Our frontal lobes, the primary strip are part of our frontal lobes, but our prefrontal cortex, that area that sticks way out here in front that gives us our personality, makes us who we are as humans, is right next to and in front of. And they think that, evolutionary speaking wise, that part of the reason our frontal cortex grew is because our motor systems allowed us to explore our environment. As you explore your environment, you need more resources and how to interact with the environment. So you can't separate movement and motor control from thinking and from personality and from just general well-being and so forth. And disruption of motor control mechanisms is the most common manifestation of a disease of the nervous system, is the most common symptom of a disease of the nervous system, is some type of motor problem. So because, again, over half of your nervous system is devoted to movement and motor systems. So what are the sequence of events that are involved when you want to do voluntary movement? This is not reflexive movement. There's always, in most movements, there's a blend of reflexive and voluntary overlap or interplay going on. This is pure voluntary. So first of all, you make a decision to move. This is one of the great mysteries of the mind. Nobody's ever, so you got to start the signal somewhere, like, to start the signal and start the first action potential, but nobody knows how we come up with initiating that first signal. When I decide I want to move my finger like that, what started the first action potential to get me to do that? So that's a really, hard, the rest of the nerves get activated by the nerve prior, but what made me be able just to sit there and decide when I want to move that? So, but you have to make a decision to move. That then, once that decision in the frontal cortex is made, it typically goes to a motor planning area in that premotor and supplementary motor area to see, hey, do I have a previously stored program or something like that that I can rely on that's done that movement before? Or is it a new discrete movement and I got to use just my primary motor strip to do that? That signal then starts to go into the control circuits. First of all, that signal goes into the basal ganglia and it makes a loop through the basal ganglia. And then that goes back up to the primary motor cortex and then allows the primary cortex to release the signal that's going to eventually go down to your muscle via your cortical spinal tract, etc., to do the voluntary movement. But it has to go through the basal ganglia. The basal ganglia is kind of like your governor or regulator over your motor system. It decides the amplitude, intensity of the movement you're going to be making, so it kind of modifies and decides some of that stuff. Also, you're getting signals coming in from your cerebellum telling you about your environment and what your last movement you did, was it correct or not? You have to modify this next signal coming down to make it look more coordinated, get you a better approximation to the target you're trying to reach for, or those kind of things. So you go down the descending motor pathways. It will often interact with some spinal interneurons before it even talks to the anterior horn cell in the lower motor neurons, or sometimes it can talk directly to the lower motor neuron without being influenced by spinal interneurons first, but a lot of times it's influenced by spinal interneurons that either upregulate or downregulate the signal, and then eventually to the skeletal muscles. We're going to go kind of in the order of your book. They kind of start lower motor neurons and some control circuits and reflexes. I wouldn't have chosen necessarily to do it that way, but that's okay. It'll all work out here. So let's start with lower motor neurons out in the periphery. Okay. Alpha motor neurons. That's the one that's going to starts in the ventral horn, exits the spinal cord via that ventral root, innervates skeletal muscle. A neurotransmitter it uses is acetylcholine. At the neuromuscular junction, the axon coming on for alpha motor neuron is large and myelinated, and it's called an A alpha. Just like we had classifications for sensory neurons like C's and 1-2s and 1A's and A betas, this is an A alpha. Sorry, it's an A alpha. That's why it's an alpha motor neuron. It's an A alpha motor neuron, large myelinated. This is just showing you. Here's a nice store of. This is a motor neuron. These are lower motor neurons. They go out into the ventral root. And then if you've noticed, when you see us on a spinal cord, if we take one out, there's actually one that's out of a body in here. There's also these are called little rootlets. So there's little rootlets that contribute to your ventral root. And you'll see these little rootlets. And that's just where it has just a few axons in each of those little rootlets that are coming out. They eventually combine into the root. And the rootlets will define basically the segment of a spinal cord. When you look at a spinal cord, the extent of where those rootlets are, that gives you the segment. You'll see the next rootlets for the next one starting, and that defines each, like C6, C7 spinal cord segments is where all those rootlets are coming out to then eventually join up to make your ventral root, then eventually your spinal nerve, which will have a ventral ramus and a dorsal ramus that will come off the back, and then eventually go to your muscle fiber. Gamma motor neurons the cell bodies are also in the ventral horn. They're right next to the alpha motor neurons because they contract at the same time. They exit the ventral root just like the alpha motor neurons. and they innervate intrafusal muscle spindle fibers, so little muscle spindle fibers, muscle fibers on each end of the muscle spindle. And they are more of they're a little slower, and there are medium myelinated A gammas. So an A gamma, so a gamma motor neuron. That's the type of axon classification. Let's define what we mean by a motor unit. A motor unit is a single alpha motor neuron and all of the muscle fibers it innervates is a motor unit. So you have these alpha motor neurons, depending on what region of the body you're in. If you're in like a lumbar spine and you're an alpha motor neuron going to the quads, you have like this, it's a massive motor neuron because it's got one big axon that goes to like, you have very few motor units in your quad because all you got to do with your quad is just contract it almost as a whole. There's not a lot of, it's not like your little muscles of your forearm and so forth. You have to contract just a few fibers here and there because you're fine-tuning your grip or you're fine-tuning certain little motions and pronation, supination, you know, all that kind of stuff. You don't need to fine-tune by firing little individual motor units. You can just fire these big, large motor units all at one time to like extend the knee, flex the knee, hold me up, you know, that kind of thing. So you tend to have bigger cell bodies and bigger alpha motor neurons going to these large postural muscles like your glutes, your quads, but in your forearm, your hand, up in your cervical spine, the alpha motor neurons are a little smaller, but there's more of them. There's a greater density of them because the motor units are smaller. They're supplying less numbers of muscle fibers with more neurons, but that gives you finer movement, gives you more gradations in how you can move. Does that make sense? So here's like the motor neuron pool. So these are all, a motor neuron pool is all the alpha motor neurons that will affect all the alpha motor neurons going to all the individual motor units that make up the entire muscle. That's the motor neuron pool, which I don't know if that's the next one. No. So yeah, the pool of motor neurons is all the ones that eventually communicate with all the muscle fibers that make up the entire muscle is the motor neuron pool. And that motor neuron pool may extend a couple segments because bicep is C5 and C6, right? So that motor neuron pool, it is in the anterior horn of C5 and C6, the alpha motor neurons that eventually innervate all the muscle fibers of the biceps. And those collectively would be called your motor neuron pool, all those cell bodies in the anterior horn that supply that individual muscle. We have fast and slow twitch motor units. Slow twitch are type 1. They innervate postural and slowly contracting muscles that turn on for long periods of time, are supportive in nature. They create the background kind of tone and ability to do fast movements on top of them with your fast twitch muscle fibers. We have different types of fast twitch muscle fibers. Don't need to get into real detail on that. Type 2A, type 2B. These are more phasic and power producing muscles, okay? It's interesting that what determines whether your muscle is a fast twitch or slow twitch motor unit is the nerve that's innervating it, the alpha motor nerve that's innervating it. The alpha motor nerve that innervates those is slightly different. And you can actually, they've done experiments where they've taken the alpha motor nerve from a fast twitch muscle fiber and switched it to a slow twitch, and it turns the slow twitch into a fast twitch muscle fiber. Not quite as good as a pure fast twitch, but it changes that to more of a fast twitch muscle fiber by switching the nerves. So you're really dependent on the nerve innervation is what does that. What's interesting is slow twitch, though, you think slow twitch fibers are slower, right? So they'd maybe be a little slower to contract or turn on. They actually fire first during most movements because they have a smaller cell body that actually depolarizes faster. And so when you're getting ready to do a quick movement, you better have your core and your postural muscles ready for that quick movement before you do it, or else you're going to throw yourself off, right? And so the cell bodies that are going to your trunk muscles as you're sending a signal down to do an activity, they depolarize a little bit sooner and go to that muscle, those postural muscles, in a few milliseconds ahead of time, they're contracting your postural core muscles before you're going to do some quick ballistic motion with an extremity muscle. Does that make sense? So that's a good protective kind of mechanism to keep, even though they fire just a little slower, but I don't know if they even really, they fire faster, but the muscle is more for slow postural types of things. So it's not necessarily that they fire slower. They actually fire faster. Remember that peripheral sensory input always is influencing your motor neurons. So you got sensory information coming in from the GTOs, the muscle spindles that give us regarding length, tension, muscle length, and rate of length. Some of that information goes up to the cerebellum to then affect the next signal coming down, because maybe the information is telling you you're not doing it right. You're moving too quickly, you're putting too much force. That information goes up to the cerebellum. That's processed in the cerebellum. It sends it back up to the cortex, so the next signal you set down says, oh, don't create so much force the next time you squeeze that cup or pick that object up. Or some of that information goes directly from the dorsal horn to interneurons and influences right at the spinal cord level, will downregulate or upregulate force production or activity of the motor neurons right at the spinal cord level. So that's what we mean by multiple levels. So you're always getting this feedback loop that modifies the next motor signal, okay, as things are happening. It's all going on. So this is just showing you that, just showing you get these multiple inputs from upper motor neurons from the brain, from the actual muscle spindles right at the dorsal horn, or from protospinal interneurons. They all converge on that alpha motor neuron to influence the signals that you're sending eventually to that muscle through that lower motor neuron, either turning it up or turning it down based on other feedback. So let's talk about alpha-gamma co-activation here that your book talks about. This concept is important for maintaining sensitivity of muscle spindles, which gives you an idea about the rate, the length of your muscle and how fast it's changing length, and the tension in the muscle. During most movements, the alpha and gamma motor neuron system function simultaneously. So as you contract your bicep muscle, you also contract the muscle spindle inside of it. And there's a reason why. So here is a muscle at rest. And typically your muscle spindle will be sending action potentials at a resting length, a baseline number of action potentials that gives your body and your brain awareness of what the length of that muscle is, okay, and the tension in that muscle. If you start to contract your muscle, what happens is this muscle spindle is inside here. It goes on slack. And what happens is now you have a drop-off in the number of action potentials that are, since there's no longer as much length or tension, you get a decrease in number of action potentials, and that tells your brain the muscle got shorter, right? But if you just left that thing on slack, when you went to lengthen it, there'd be slack in it there would be delay before you started to stretch it again to tell yourself that it's stretching again. And also, once you've got it the new length, if you don't have any action potential sending signals, you don't necessarily know what the new length is. So what you do is, when the muscle shortens, as soon as it starts to shorten, a little bit slower, because remember the gamma motor neurons are they're medium myelinated, a little bit slower. A few milliseconds later, the gamma motor neurons come in here and they take up the slack. They tighten up the ends, so the length is now similar to what it was in the resting length muscle in the shortened muscle. And so then it begins to send its baseline signal of, now this is the new length I'm at, and I can tell what length I'm at. And now if I do start to stretch it again, I'll immediately get another signal saying I'm being stretched again. Because if you just left that sloppy slack, muscle spindle in there, there would be a delay when you started to stretch it again. And also, if you left it on slack, you wouldn't even be able to sense this new position. Does that make sense? It's called setting like the sensitivity or the gain in it, okay? And what you do with like stretching, if you stretch muscles and you basically change the baseline sensitivity or the number of action potentials that muscle spindle sends at a baseline rate. If you just, the muscle spindles can habituate to stretch. And so if you take your muscle spindle and stretch it out a little bit and hold it there for 30 seconds, a minute, it'll start to actually downregulate the number of baseline impulses it sends. And so then your muscle thinks it's not it's not as short as it used to be, and it says, oh, and it relaxes a little bit. So and that's how you can get. Most stretching is neuromuscular in nature. You're just decreasing the sensitivity of the muscle spindle a little bit. And if you stretch all the time, you stretch daily, you maintain that slightly decreased sensitivity of the muscle spindle by keeping constant tension in it all the time. It doesn't like that, and it just says, oh, I don't want to be overstimulated. I'll down-regulate just a little bit to accommodate for this new. This appears to be a new resting length this body is trying to create for me. So I'm going to down-regulate a little bit, so that when you do stretch the muscle quickly or do something, it's not quite as sensitive a little bit. So you're decreasing the sensitivity, which can be good or bad. Sometimes you need that sensitivity to make sure you don't get injured. So there's evidence now that if you do a lot of stretching right before you go and do a ballistic sport activity, it doesn't help. It may even make it worse. You may actually decrease the sensitivity so your body doesn't know exactly where it is in space as well, and you're a little higher risk for pulling a muscle than if you'd basically they say just do a longer warm-up of actual movement that you're going to do in your actual skill or task. If you're going to do soccer, do a half-hour warm-up of the skills you're going to be doing and do it progressively for a half hour from, don't sit and just do static stretching. That's probably more harmful than good. So, but for patients that have a lot of spasticity and tone or have true contractures or a risk for contractures, stretching is good. We want to maintain range of motion. Or for people like us who sit all the time, eventually our muscle spindles get tighter and our muscles get tight. We need to stretch and maintain a certain amount of range of motion. Basic functional normal range of motion is important to have. So let's pause here before we jump into the spinal region. Any questions on that? It's interesting. I think it's kind of interesting concept. All right. Interesting is there's a lot that happens just in the spinal cord with very little influence. I mean, there's some influence, but a lot of motor control happens right at the spinal cord level, with these basic reflexes and basic influences over motor output at the spinal cord level. So let's talk about a few of those common ones we know of. First of all, the concept of myotomes. A myotome is just the group of muscles innervated by a single spinal nerve is a myotome. So that's spinal nerves coming out of the spinal cord, or primarily innervated by a single spinal nerve. And you guys have done a myotone screen, and these are the movements you go through when you're screening that to primarily screen that nerve root. Okay, we know that there's overlap. Elbow flexion has both C5 and C6. But it's a little more C5 than C6. So if somebody's got a C5 problem, they're going to be really weak. If they've got a C6 problem, they're going to be slightly weak in their elbow flexion. And then you get to wrist extension, same thing. If it's C6, they're going to be really weak there. So that's how you can kind of define. If you have one that's like a C5, C6, if you go down to the next level, it's also weak. Then you can kind of help to determine which of the nerve roots is more involved than another. Just showing you in the spinal cord cross sections about. Remember I mentioned that here's a cervical spine cross section. This is the anterior horns in the cervical spine. Look how big they are, and they even have a little convolutions on them and so forth. It's just because you have a lot more anterior horn cells in there because they're going to all those muscles of your hand and forearm. So you have these smaller motor neuron pool. I mean, you have smaller motor units, but more anterior horn cells going to lots of small motor units, okay, because you have such complexity of movement there. And then, man, look at this. This is in the thoracic spine. This is really down kind of low in the mid, like right in the mid-thoracic spine, maybe, T7 or 8 or something like that. All it's going to is a few intercostal muscles, some of your maybe rectus abdominis and obliques in that region, so there's not a lot of muscles that have to supply. And those are also probably much larger motor units because you just got to contract that muscle. It doesn't grossly, you don't have to contract a little portion of the muscle to get the movement you're looking for. And then down the lumbar spine, we have some larger ones again. They get big again because you have these really large muscles, and plus you get, when you get down into the lower leg and the foot intrinsics, you start to again have a large number of muscles, and so they start to get a little bit larger. Motor neuron pools we mentioned already, but these are the axons from a motor pool that project to one muscle. When we look at the motor neuron pools inside a spinal cord segment, we can divide them usually into like a medial pool, a lateral pool, an anterior, and a posterior pool. And there's certain, the axons or the motor neurons that lie in those tend to go to certain parts of your limb. And so if the anterior horn cells and lower motor neurons that lie in the medial pool or start in the medial part of your anterior horn, they tend to go to axial and proximal muscles. If they're more in the lateral pool, which makes sense, they go to more of the lateral muscles. If they're more towards the anterior pool, they go to extensors, and if they're posterior, they go to more flexors of your body. The picture makes more sense here. And this is a good picture to help remember this. Think about an arm, being flexed inside of this anterior horn. This is true for both the leg, but the leg doesn't make as much sense. But the principles are the same for the leg. So if you think of this, so lateral, this is lateral. Anterior horn cells that lie in the lateral area of the ventral horn tend to go to more distal muscles. And then ones that lie, anterior horn cells that lie more proximal, or more medial, I should say, when they go out, they're going to more proximal muscles, shoulder girdle, scapula, those kind of things. The more anterior they lie, the more they're going to be going to extensor muscles, and the more posterior they lie, the more chance they're going to be going to more of a flexor muscle. Okay, so if you lie anterior and medial, you're likely to go to more of the proximal region of a flexor muscle. If you lie more distal and anterior, or lateral, I should say, and anterior, you're more likely to go to a distal extensor muscle. Does that make sense? So, yeah. Really, thoracic doesn't matter so much. It does still hold true for thoracic. It just is not as important because you're just talking a few muscles around, but it does hold true for the leg as well. Yeah, and you'll see, I think I've got another picture here that represents the leg and shows some of that. So this shows you kind of that same thing where these things lie, and then where they kind of go to as far as flexors and extensors and more proximal and distal. But again, and there's a reason for that, is like when we talk about the medial and lateral activating systems, which are the tracts that are carrying information from your brainstem and cerebrum to go interact with these, the lateral activating pathways run down in the lateral funiculus of your spinal cord. So they're going to go to the motor neuron pools that are more distal. They're closer to where the motor neurons are more distal, or more lateral, I should say, more lateral and a little more posterior. Lateral this way and a little more posterior. So they're going to bias more flexors, distal muscles of the flexors, flexor muscles and distal. And where the medial activating pathways tend to run down in the anterior funiculus of your spinal cord, and they synapse with anterior horn cells that tend to be more proximal extensor muscles. So there's a reason for that kind of somatotopic arrangement, because that's where they're close to the pathways coming down that are going to tell them what to do, that are biased to those particular functions. So there's different things that can influence. We have these pretty sophisticated abilities to coordinate some movement at the spinal level itself. These are through things called like muscle synergies. Once you start to contract a certain muscle, often other muscles will contract with it because they're actually nearby, and you actually get some communication. There's actually communication within your spinal cord that will tell a group of muscles to work together. Things like lifting your leg up if you step on a sharp object. There's a muscle synergy that pulls your leg up off that sharp object that makes your hamstrings flex, your hip flexor flex, your dorsiflexors come up. Same thing when I bring something to my mouth. This is a muscle synergy that is very common. That is elbow flexion, shoulder abduction, supination, some shoulder girdle retraction when I bring something up to my mouth. Or if I do a certain motion where I reach out this way, this is an extension synergy when I go to reach away from my body in this position here. And so you'll see when some of these synergies become more dominant or interfere with movement in people with stroke, because they can't move out of them. These synergies are kind of pre-programmed, and then if you don't have normal control from higher centers to keep them at a right level of activity, so you can, if you don't want to use them, you don't use them, or you can move out of your synergy, but they become more dominated by these primitive synergistic patterns that are more in the spinal cord and brainstem level, because they no longer have, like if a person has a stroke up in the cortex, to allow them to move out of those synergies when needed, as needed. So we'll explain some of that. We have basic stepping pattern generators called CPGs, or they're called central. CPG stands for central pattern generator. Once you start walking, especially as a walking is where we see these the most, is once you send a signal from your brain to say, start walking. Once I start walking, my walking will just keep going on its own until I say, stop walking. And I don't have to keep sending a bunch of signals from my cortex to keep me walking. Once I start the process of walking, spinal cord reflexes say, all right, once I've taken that first step, oh, there's a stretch on my hip flexor on the leg left behind, and I feel pressure differently on the bottom of my foot. That means I'm ready to go into swing, so I'm going to go ahead and do swing. And then now the same thing happens, and you get this reciprocal pattern by stretching hip flexors, stretching certain ligaments and tendons, changes in pressure on the bottom of your foot that all are done right at the spinal cord level. You can maintain a very basic pattern of walking with no input from your higher centers. And they did this, these are the studies they did in cats, mainly in four-legged animals, where they would transect their spinal cord right at the brainstem and spinal cord, completely transect it so they had no input from higher centers, put them on a treadmill, and they start walking. That's central pattern generators that are keeping you, because the treadmill, they couldn't send a signal to start the walking, but if you put them on a treadmill and you start the treadmill, it starts pulling their leg back, it stretches their hip flex, and they go, oh, I need to take another step. And that's all a spinal segment. And then the next leg goes because of these central pattern generators. So you have communication at multiple levels in your spinal cord that allow this primitive stepping motions. Same thing with your arm swing is the kind of same thing. There's an arm swing that goes along with walking too. Some of that's momentum that does that, but some of it's some central pattern generators just to keep your arms counteracting your stepping. We have basic reflexes. We'll talk about like just basic withdrawal reflexes, cross extension reflex, and things like that. And then the concept of reciprocal inhibition is something that happens at the spinal cord level, where if I'm extending my knee, I inhibit my hamstrings at the same time. That all happens at the spinal cord level. I don't have to think about it. I don't have to tell from a higher center to do that. It just happens automatically. If I flex my elbow, my triceps are inhibited so they don't stop me from flexing my elbow. So going through a couple of these, just showing you some specific examples. Here is somebody extending their quad. The muscle spindle says, hey, he's contracting his quadricep muscle. I'm getting shorter. I'll send my signal via my 1As back to the spinal cord, and via a inhibitory interneuron connection, I will send a signal. This will not happen at the same exact level here. Hamstrings might be S1, S2. It's actually going to go down in the spinal cord a little ways before it does this. This is just showing you a very simplistic model showing this all happening at the same cross-sectional level. This is actually happening down a little lower, but it'll send a signal down to an inhibitory interneuron to inhibit the hamstring so it doesn't interfere with your ability to straighten your knee out. You don't want it restricting that. That's reciprocal inhibition. At the same time, that shortening of the muscle spindle, it'll actually enhance and be facilitatory to the agonist, to the actual muscle it's embedded into. So you'll be contracting your muscle, and you'll send a little self-stimulating feedback loop to continue contracting it until you send a signal from a higher center to shut it off. Or you reach certain limits in the muscle as far as how hard it's contracting or what the need is, where it shuts itself off at the spinal cord level through interneuronal kind of activation and things like that. So. Reflexes were once thought to be the sole basis for movement by early scientists. They thought everything was a reflex, and we'll talk, like they call it reflex chaining, you know. So we'll show you when we talk about reflexes and motor control in the clinical neuro. We'll give you some examples of that. However, most movement is voluntary with some contributions of reflexive movement. Now, there are certain movements that are very reflexive in nature that aren't voluntary at all. When you get destabilized without you knowing you're going to get destabilized, somebody comes and knocks you over, or you slip or trip, that's almost purely reflexive. There's not enough time for you to generate a voluntary contraction to compensate for that. But most movements we do are anticipatory in nature. Most movements, we're choosing to do a movement, so we have some expectation of what that movement's going to be a few milliseconds or seconds ahead of time, and we've done it maybe a movement similar before. We have some stored programs that we can access, and we then start to do it. But if something changes during the movement, reflexes help modify the movement if something changes in the situation, the task, the weight of the object I was going to pick up. If I went to pick up an object that I thought was a certain weight, you all done this before, the box or something, and you think it's light and you go to pick it up and it's heavier than you thought. Well, as I go to pick that up, I had a certain tonal set and muscle program I was going to use for that. It's not working, and all of a sudden as I'm trying to lift that box up, it's not coming, and instead of my biceps shortening, they're lengthening because I wasn't prepared for it, so they're lengthening. The muscle spindle gets lengthened. That sends a signal back to the spinal cord. It says, upregulate, come on, summon more help, and that quick stretch makes your muscle fire more strongly, and that's the superimposition of the reflex on top of the original voluntary act. So in reflex examination can give us some idea of the integrity of the motor system, at least at the peripheral and spinal cord level. So stretch reflexes is one way we can look at that. Just tapping on a tendon, it's a monosynaptic stretch reflex. We're stretching the muscle spindle briefly, tapping on the tendon, which pulls the muscle, right? That's what we're doing. And there's only certain muscles it's easy to get a nice tendon tap to get that quick stretch. They have to be a little bit longer muscles, and they have to have enough of a tendon that you can get a little stretch. Shorter little muscles, you can't tap on certain muscles in your face and those kind of things. It would not be polite. So that causes that reflex to go back and then send a signal back to the muscle that facilitates the agonist, the muscle that is embedded in. It's autogenic facilitation. That's the same concept. The reason you have those, that same concept I was just saying, is if I go to lift an object and it's too heavy, I start stretching that muscle really quickly, and it creates an autogenic facilitation to strengthen that muscle. Or if I'm just standing here, we all have a little bit of sway when we stand, and if I start to sway far enough forward, eventually my gastrocs stretch enough that I stretch the muscle spindle, sends a signal back to my spinal cord and says, gastrocs fire, bring me back to midline. Then the same thing going back this way. If I start to go back far enough, my anterior tibs get stretched and they pull me back. But it keeps me in a tight little range there with a certain amount of sensitivity of my muscle spindles to keep me from swaying. GTO we talked about before when we talked about sensation, the Golgi tendon organ. It relates information regarding tendon tension. It helps to modulate muscle contraction and tension around the tendon. It works with other proprioceptors. It doesn't work by itself. We used to think it was an on-off switch for muscles. We used to think the GTO, when you created too much tension in the muscle, the GTOs would get stimulated and just shut your muscle off to protect the muscle so you didn't injure yourself by contracting it too hard. However, we now know that it can either facilitate or inhibit based on the task. Based whether you're standing or whether you're like in stance or swing, the Golgi tendon organ will help facilitate or inhibit based on the actual task you're doing. Its main role, though, is to distribute tension along your tendon more evenly so you don't tear or strain one part of your muscle tendon over another area. So I'll show you here. So this is showing you, here's the GTOs. GTOs are, again, this is the musculotendinous junction right here. And we're showing some segments of the muscle here. So we have 3 segments of the muscle that are being innervated by alpha motor neurons, okay? If this central region of the tendon, that GTO in the central part of that musculotendinous junction, it says, oh no, I'm getting a lot of increased stretch here. There's too much tension in this one region of my musculotendinous junction. That GTO can send signals back, and via an inhibitory interneuron, in this case, can tell this region of the muscle, let's turn ourselves down a little bit. And at the same time, the GTOs on the other side can tell the other regions of the muscle to turn themselves up a little bit to protect this region of the. So they can do both. They can be both inhibitory or stimulatory, but all they're trying to do is distribute the tension most evenly across the musculotendinous junction so you don't damage one region or get like a partial tear in muscle. Trying to distribute the load most effectively at any given moment across that musculotendinous junction. And that's the GTO plays a role in that. We have these things called cutaneous reflexes. Cutaneous means surface of your skin, so on your skin. So when you touch the surface of your skin in a certain region of your body, or you poke a certain region of your body with a needle or something like that, or a pin, it will create a reflex based on that. One of the things we have is called the flexor withdrawal reflex. This happens in the upper extremity. You stitch your hand on a hot stove, you pull it away. That's a flexor withdrawal reflex right there. You never thought about that. You don't even know, your hand is here before the pain hits. And Same thing with the leg. You step on an object that's sharp, boom, you'll pull your leg away. Or somebody tickles your foot, which is perceived as noxious stimulus. You're going to pull your leg away in a very stereotypical flexor withdrawal reflex. It's a multisynaptic reflex. It involves multiple levels of the spinal cord. So you see, here's the sensory input. This is a bottom of your foot and the pin. This person stepped on a pin here. The pain signal on an A delta fiber goes into the posterior horn of the spinal cord. It travels up and down multiple levels via that posterolateral tract of Lissauer, or Lissauer's tract. That's right. When it comes in, remember we said sometimes pain goes up and down multiple levels. One of the reasons it does that is because if you need to elicit a flexor withdrawal response, you need to go tell multiple levels of the spinal cord, because you need to get the hip flexors to turn on, you need to get the hamstrings to turn on all at the same time so that they'll pull your leg away without ever going to your cortex. It'll be too late by then. You already have the needle or the nail will be through your foot by then. You have to have this happening right at the spinal cord level. So it's multisynaptic, and it can involve multiple levels. It can also involve the opposite side. So this can go to the opposite side and cause the cross extension. So especially this is most important for the leg, because you're standing. If I all of a sudden step on a sharp object and pull this leg up, I better make this leg have the ability to hold myself up all by itself. So I have to send a signal to the other side to tell it to extend and accommodate my weight, because I'm about to pull this leg up. I got to make sure this leg doesn't collapse. So that's the cross extension part of this. You typically don't see it in the upper extremity if you're not weight bearing. If you're weight bearing, though, if I go down and do something like this and go down, whoa, and I have to pull like my arm up like this while I'm in weight bearing, I'll get a cross extension on this side. But if the body knows that there's no pressure on the palm, it knows I'm not weight bearing, so it'll do a cross flexor withdrawal response. Same with like instead of 5. So what makes it a lateral activating pathway is they tend to run down the spinal cord a little more laterally, and they tend to interact with those motor neurons in that lateral pool, and also more posterior and lateral pools that go to more flexors of the body and more voluntary muscles, kind of thing, not so much postural muscles. However, there is one pathway. So the two of the pathways still start in the start in the brainstem. And even though they're part of the lateral activating pathways, they still start in the brainstem. So I remember I said the medial activating pathways, pretty much, most of them, 4 of the 5, start in the brainstem and tend to be more primitive in nature. There is some brainstem pathways that still tend to do more flexor control and help the lateral corticospinal tract. So it's more for fine and fractionated movement, okay? And fine and fractionated movement tends to involve more flexion. Bringing things to your body, manipulating objects tends to be more flexor biased. Gross movement against gravity tends to be more extensor biased. So these are more flexor and voluntary fractionated movement. Like fractionated movements means like moving individual fingers from the other, not gross movements of limbs, but fractionated. I can then manipulate objects and those kind of things. So that's what we mean by that. Let's see here. So that's the ones I circulate, the lateral or medullary reticulospinal tract. So it's these 3 right here are the more lateral activating pathways. You'll notice see how the rubrospinal tract actually runs right. This is the lateral corticospinal tract, and there's actually some overlap of fibers there. So they're running right next to each other. Rubrospinal tract just has a little excitatory or helping input to the lateral corticospinal tract, especially for flexors of the upper extremities. Helps ramp them up a little bit. Rubrospinal tract is actually much more pronounced in primates and monkeys that climb, that do a lot of climbing and flexion of it's smaller. We don't do as much like that. We're not using our arms all the time in big motions to do lots of climbing and so forth. So let's start with the lateral corticospinal tract. The lateral corticospinal tract is the one that you may have learned of. What did you get? Is that chili or? Chili. Nice. That's a big bowl of chili. What? Yeah. Well, hopefully we'll be done before that chili starts kicking in. No, you're fine. So, do you put ketchup in your chili? Am I the only one that puts a lot of ketchup in their chili? Because I don't like spicy stuff. I love lots of ketchup in my chili. What? Does anybody else put honey on their grilled cheese? I do honey on my grilled cheese. I like that. I need to have that little bit of sweetness on it. Try it. Honey on your grilled cheese, ketchup in your, or cottage cheese in your chili? No? Sour cream. Yeah, or cottage cheese. What's that? I just drizzle a little chili. Which one? Chili or the grilled chili? I just put it on afterwards. I just put ketchup in afterwards, just to tone it down to my taste. I know it's sacrilege to do that. All right, lateral corticospinal tract. Function, primary function of the lateral corticospinal tract is fractionation of movement, the inability to activate individual muscles independently of other muscles. It mostly supplies the upper extremities. We'll show you in a second what proportion or percentage of the fibers go to different regions. But it begins in areas 4 and 6, the primary and supplementary and premotor areas of the cerebral cortex, same as the medial corticospinal tract. It runs through the exact same parts of the corona radiata, posterior limb of the internal capsule, crus cerebri, ventral pons, pyramids, but then it crosses over. Once it crosses over, it becomes the lateral corticospinal tract. So 85% of these fibers coming down cross over to become the lateral corticospinal tract. The remaining 15%, that's your medial or anterior corticospinal tract. So these are the 85% of the fibers that cross over, and then they run down that lateral part of your spinal cord as the lateral corticospinal. Starts in the cortex, ends in the spinal cord, runs a little lateral, so it tells you what it's doing, where it's going. It terminates on neurons or interneurons in the ventral horn and more on that lateral posterior ventral horn that goes to more distal flexor muscles. 55% of the fibers terminate on upper extremities, 20% to the trunk, and 25% to the lower extremities. So you can see the greatest proportion goes to your upper extremities just because there's so much more fine fractionated movement occurring in the upper extremities. So that's the lateral cortical spinal tract. So it's all of this running down through the crus cerebri, or let's say corona radiata, internal capsule, crus cerebri, ventral pons, pyramid, and then all the fibers that cross over, that's the lateral cortical spinal tract. So this is a very contralateral pathway. You have to know this. The lateral cortical spinal tract is contralateral, and when you have damage to this pathway, anywhere in the cortex or in the brainstem, you're going to have contralateral loss of distal fractionated coordinated movement, opposite to the side of the lesion, if the lesion is up in your brain or in the brainstem, till it crosses over. Before then, if you have that damage up in that central nervous system, it's going to be contralateral loss. Unless it's in the spinal cord, then if it's a spinal cord, then it's ipsilateral loss, because once it's a spinal cord, it's on the same side as the muscle it's going to. Does that make sense? So if you have damage anywhere along this pathway in the cortex, brainstem, you're going to have contralateral loss of function. If the damage is in the spinal cord, it's going to be ipsilateral because it's already crossed over. We'll get to that when we get to spinal. We're going to do all that kind of stuff again, where injuries. I'm just starting to introduce you to clinical concepts of where you have lesions and so forth and what it causes. The next one that your book doesn't mention is the medullary or lateral reticulospinal tract. So medullary, so this one happens to start in the medulla, and it's in the reticular formation of the medulla, where the other one was the pontine reticulospinal tract. So this is the medullary reticulospinal tract. It's lateral because it's part of the lateral activating system. Okay, and it runs a little more laterally. It's positioned a little more laterally than the pontine one that is more medial when it's in the spinal cord. So what does it do? It's regulation. It's regulation of tone. It tends to be, when it's doing its baseline job, it tends to be more inhibitory than facilitatory. And in order for it to do its job, it requires input from higher centers in your cortex functioning properly. It tends to then facilitate flexors and inhibit extensors. So it tends to be a counterbalance to all your other medial activating pathways that tend to bias extension overall. This guy biases flexion a little bit, okay? Because you want some balance there, but we tend to be more extensor creatures, you know, but this one biases a little bit of flexion, so that's why it's part of the lateral activating system. It helps with flexion. But it requires input from the cortex to do that job effectively. So if your cortex gets damaged or higher above it gets damaged, it can't do that job as effectively. It can't keep your flexors facilitated, and it can't inhibit your extensors as much. And we'll get to why that's important later. However, when you're doing when you're walking, it actually has the opposite effects. It knows if you're upright and walking, it says we better turn it into more of an extensor bias system once we know we're upright and walking. So it knows to turn on and do less for the flexors and do. When you're sitting or not walking, it tends to bias more flexion. It's just interesting how, and that's because of input from your bottom of your feet that go up to your brainstem and tell you you're upright, and your vestibular system also talks to that. There's connections within your nervous system through interneurons that tell you I'm walking now, so I'm gonna change my function a little bit. Where does it begin? It begins in the medulla, in the medullary reticular formation. So medullary reticular formation. So here's the medulla right here. This is pons still up here. This is the medulla. This is the pyramids right here. So this is the reticular formation. That reticular formation is in the tegmentum, in that middle section of the medulla. And actually, this region that it starts in, you don't have to memorize this, but it's called the nucleus gigantocellularis. There's several things that originate from that, but this is one of the things that originates from the nucleus gigantocellularis. It's just, if you're reading and they talk about the nucleus gigantocellularis, it's just that you know that, and you're talking about a motor system thing, that's where the origination of this reticulospinal tract is. It descends both ipsilaterally and bilaterally. It's really not a contralateral tract. It's either ipsilateral or bilateral in nature. So I would just say it's more bilateral nature. It's going to more postural muscles, but it's going to influence postural muscles. And if it's functioning properly, as long as you're not walking, it's making you a little more biased towards flexion when it's working properly, a little less extensor tone. It's balancing the extensor tone of the other tracks. And where does it terminate? Just motor neurons of postural muscles and limb extensors. Rubrospinal tract. This is the next one. Rubrospinal tract. This is a function, question mark, for in humans. They're still trying to figure out exactly what it does in humans. But what they think it does is that probably helps to bias flexors of the upper extremity, helps to make your upper extremity flexors be a little more effective and active when you're doing fractionated movement. When your lateral cortical spinal tract is telling you to bend your arms and your fingers and do flexion, rubrospinal tract helps assist that a little bit, okay? More developed in primates, monkeys and all that good stuff. So where does it begin? It begins in a red nucleus, right here. This is the midbrain, right? That's that cross-section. That's that butterfly-looking kind of upside-down butterfly-looking kind of cross-section that we recognize as the midbrain. It starts there, and the red nucleus is kind of cool, and you could actually take a cross-section through a little midbrain, and I'll take out a brainstem this year and cut through, and I mean, the brainstem is tiny, and that midbrain is really tiny, but you can see that little red nucleus on there, and it is kind of red in nature. That's why rubro, red nucleus, rubrospinal tract. That's what it means. Rubro starts in the red nucleus, rubrospinal. It immediately crosses over in the ventral tegmental decussation of the midbrain. So this is the midbrain. This whole region right here is the tegmentum of the midbrain, and it crosses over a little more ventrally in that tegmentum. That's why it's called the ventral tegmental decussation. And then you have the red nucleus here doing that, so you've got a crossing over point of those rubrospinal tracts. That's the ventral tegmental decussation. It descends in the tegmentum of the pons. So here's the pons, this whole region. It's just kind of sitting there in the tegmentum. It's hard. You can't see that track or define it. It's just pretty, when it's running through the pons. You're not going to see that on a cross-section, actually. Runs down and then joins the lateral cortical spinal tract of the spinal cord. Once it gets down here, it joins the lateral, up with the lateral cortical spinal tract, like you saw in that picture where it shows it almost part of, just laying right up against it. But it's still called the rubrospinal tract in the spinal cord, okay? But it just is running right along with the lateral cortical spinal tract. So where does it terminate? On motor neurons or interneurons in ventral horn to supply various muscle groups with an emphasis on upper extremity flexion. This tract also, in order for it to function and behave properly, it has to have some input from higher centers, from your cortex. So when you have damage to your higher centers, it lets this guy run amok a little bit. It gets a little too overactive. It overactivates flexion muscles, and so that's why your stroke patient who has a stroke in higher centers, now normally you keep this guy moderated to give an appropriate amount of facilitation to upper extremity flexors, but not too much. When you lose that normal control, the rubrospinal tract gets overactive, and now your arm sits like this and is overactive into flexion. When you have a stroke from the cortical spinal tract fibers that have little branches that go to it to tell it what to do under normal conditions and keep it at bay so it works at a right level. When you lose that moderating influence from your higher center, it's overactive, and that's why they tend to have their upper extremity flexed. And then your medial activating pathways make your lower body extend and be overactive into extension because you no longer have the moderating influence from the cortical centers over some of your medial activating pathways, and you get too extended in your trunk and your leg and too flexed in your arm. And that's why they have this characteristic stroke patients or MS patients or anybody has damage to their cortex or the white matter in their internal capsule, they have this kind of a posture. Flexed upper body, extended lower body, and the opposite side of the lesion. Because of the rubrospinal tract being allowed to kind of work unencumbered and create too much flexion, and because of a combination of your medial activating pathways not being overactive too, and making too much extension in your leg and trunk. Okay. This is a pure contralateral pathway. I would remember that the rubrospinal tract is pure contralateral pathway, and the lateral cortical spinal tract is a pure contralateral pathway. So if you have damage to the left red nucleus, you're going to have problems with your right upper extremity flexors. It's pretty uncommon to have a red nucleus lesion, but it can happen. We're just going to mention briefly the cortical bulbar tracts. These are the motor supply to the muscles of your head and neck and mouth and tongue and those kind of things, especially for voluntary movement. Okay, so this is cortical bulbar. These are the fibers going from your cortex that are going to your cranial nerve nuclei that you say, stick out your tongue. I can stick my tongue out. Open your mouth, you know, turn your head, you know, cranial nerve 11. So all those things are driven by the cortical bulbar tracts, allow you to have voluntary control of the muscles innervated by cranial nerves. Okay, close your eyes and hold them tight for me. That's a cortical bulbar function that allows me to do that. There's reflexive things that happen in our tongue and our mouth and our eyes that aren't part of the cortical bulbar system. This is the voluntary control over your cranial nerves that you have is the cortical bulbar tracts. The thing you want to remember, all of these pathways are crossed. They're all contralateral pathways. Like our lateral cortical spinal tract, the cortical bulbar tracts all cross over. And they actually run with the cortical spinal tract fibers coming from your cortex. They go through the internal capsule right here. They go through the crus cerebri. They go through the ventral pons. But then they just terminate on the cranial nerve nuclei they're going to on the opposite side to drive the motor function of those cranial nerves. There isn't a little exception to this. There's actually a little more bilateral connection to just the muscles of your upper face. The facial nerve nucleus, the upper portion of the facial nerve nucleus, actually happens to have a little more bilateral innervation. So stroke patients or patients with a tumor in one side of their brain, they might have the right side of their face is droopy, you know, on the right side, like their tongue is weak on this side, their eye is weak on this side, but their upper forehead has pretty normal function. They, like if you tell them to raise their eyebrows, it might be more equal because the upper part of your facial nerve nucleus that goes to the muscles of the upper part of your face, there's more bilateral connection. So even though the stroke is over here on the left, causing weakness on the right hemisphere is also supplying that side as well, on the upper part of the face. It's not pure. There's still maybe a little more weakness, but they'll have less effect on the upper part of the face, more effect on the lower part of the face. I hate those exceptions. There's always these darn exceptions. Your book also mentions a few we call non-specific activating pathways. These include the cerebrospinal and raphe-spinal tracts. And remember, we talked about some cerebrospinal and raphe-spinal tracts as they play a role in descending pain modulation, but they also play a role in descending motor modulation. These pathways, from these primitive pathways from your brainstem, go down and connect to interneurons and alpha motor neurons in your ventral horn and just give generalized effects on motor performance and motivation. This is where they think, you ever heard of like the yips, you know, or like, oh, you freak out when you're trying to make that putt for $1 million, you know, and it's because of somebody with an overactive cerebellar and raphe spinal tract. So normally they can do this with but all of a sudden the limbic system is driving the cerebellar and raphe spinal tracts to ramp up, and they create too much tension in your muscles, then you get too much coactivation, and then you start to try to make it, you have too much of an over amplitude of your, you know, that's why I could never play golf. I was like mentally weak. Like anything would screw me up where I would just get, you know, that mind block, that, you know, choke, you know, kind of thing. So this is like where the choking comes from, is the cerebellar and raphe spinal tracts not having good control of those. And you can, you know, people that are just good at that or practice enough that they can down-regulate those and keep their limbic system calm enough to not ramp those guys up, can maintain their performance even under highly stressful conditions. Where most people, at a certain level of stress, your performance goes up, but then you exceed that level of stress and your performance starts to go down, especially with skill-based stuff that's like requires fine movement and skill. These guys get a little overactive and screw you up sometimes. So motor areas of the cortex we're going to talk about. Now we're up on the cortex here. We moved out of the pathways in their spinal cord and brainstem, and now we're in cerebrum. Now we're up on the motor areas of the cortex. Primary motor area is area number 4. Brodmann's area number 4 is the primary motor strip that has the homunculus on it. It is for movement, execution, and fractionation. So really voluntary, I'm going to move this joint this much, and I'm going to do this very specific activity. I'm going to push this button, on my phone. That's what the primary motor strip is for. And 50% of it is devoted to just hand function and speech. Because just to move your tongue, mouth, to move your fingers requires so much control that you have a large part of real estate devoted to that. Then we have the supplementary motor area, which is just in front of that primary motor area and more superior. Okay, it is more active, and it plays a bigger role, especially in activation during prior to bimanual tasks and things that require a common sequence of movements. So buttoning a shirt, my supplementary motor area, in this, especially if I've done this a long time, when you're first learning to button a shirt for the first time, your primary motor strip is very active in addition to your supplementary motor area. But once you've learned to do it, you can sit there and have a conversation while you're buttoning your shirts because you have your supplementary motor area is doing it kind of for you. It's got a little bit of a pre-programmed program for that, and it's a bimanual task, especially a thing that requires you to work with your two arms together. We're talking mostly upper extremity when we talked about bimanual, unless somebody was born without arms and they use their feet to play a guitar or something, or you're playing a guitar with your hands. But even your supplementary motor could be active if you don't use your arms and you're using your feet for something skilled that requires bimanual manipulation or something like that. Or sequential tasks like sit to stand is kind of a sequential task, and then going from that to walking, there's a sequence involved with the transition from one skill to the other. Or making a sandwich, that's like you're using both hands, you're spreading this, you're putting the, you do a very kind of, and all of us learn our way of doing it, and that's stored in those premotor, and supplementary motor areas. Then premotor areas are active oftentimes with the supplementary motor area, but in particular with generating patterns of movement involving multiple muscle groups and joints, which the supplementary motor area is often during multiple joint movements and sequential movements. But premotor area with things, especially that require rhythmic things. Walking's pretty basic. Well, it's not so active during walking because walking's more spinal cord level, but I'm thinking more things like the upper extremity, like it might be swimming, a swimming task, or swinging a baseball bat and those kind of things, or something or playing tennis or something that rhythmic and but requires groups of muscle patterns and so forth that you've done before, so it's partially stored there. And so as you learn a new skill, you start to store these things. You don't have to use your primary motor strip. You use these premotor areas that are active even before your primary motor strip, but also your basal ganglia and cerebellum are involved in these things too, of storing some of these programs and activating those. So I've already shown you where those are. There is a motor planning area. I'll show you here, which we'll get to. So all of these areas, these are all collectively kind of premotor areas, but we have the supplementary premotor, but then we have the similar thing for just the speech, Broca's area. That's the motor planning area just for your speech centers. These areas are for your body. Then you have this big area just for speech. When we get to the speech, when we get to the cortex, we'll talk about Broca's area, what happens if you have damage to that. It makes it so you have difficulty generating meaningful speech because you can't plan it. Not because your muscles are weak in your tongue, but you just can't plan how to put together the signals to make make it sound like a word. Not because you have weakness, it's because you can't plan it. Dang, we actually finished early? I thought we were going to be running late on this. You guys are like the superstars, because normally this lecture normally takes at least a good 1.5 to 2 or am I making too big of an assumption there?